So I think one of the most important lessons I ever had in EMS was the concept of well or not well. I remember talking to a doctor um, about cardiology, honestly, when he kind of introduced me to this principle. But he said, uh, during that first week of residency, he takes little docklings and he's like, we don't even let them look at the charts initially. We just walk them room to room and say, hey, so what do you think? Well or not well, right? Like, and it's not everything, it's not like, oh, okay, I think well, I'll leave, but it's definitely important, I think, in the old westerns to kind of develop a certain skill to just draw off the hip and be like, okay, where am I immediately, right? And it's definitely a super important thing, and we got to be careful sometimes because we might look at a person and say, oh, okay, well, clearly not well, and then clearly well, where of course she could just be sad, and maybe this patient has some advanced stage of dementia. And so looks certainly can be deceiving, but we're learning that largely now. Plus cute baby. We want to stay in communication with people. I used to say all the time in the field that there are patients that I need to talk to figure out what's going on, and then there are patients I don't have to talk to know what's going on. I don't know, especially now that I teach, I don't know that that is explicitly true and should be said as much anymore, but it's important to kind of have just a concept in your mind where I walk in and the guy is just like spraying blood out of his mouth or whatever. I'm not like, sir, are you a diabetic? It's like, well, I'm not saying that's a bad question. It's just poorly timed, right? So there's a whole host of different reasons. And largely what we're going to get into is just disease processes in general, right? As I start my hip hop album. Now, one of the things that we should mention about a disease is that I think that it's largely confused as, oh, a virus, whereas a disease is largely the abnormal presentation of a thing. Like a heart attack is a disease process. It's not one that you can catch, so it's not an infectious disease, but it is a disease. It's a pathology. Now, I won't spend a bunch of time here except for to say this is a slide full of vocab, and that vocab is important. I don't expect you to know the names of any bacteria or fungi or viruses except for hepatitis and MRSA and C. diff and HIV. Okay, so there's a few viruses I suppose you need to know the name of, but you don't need to know a lot of them. Just essentially the stuff you probably already knew before coming in here, unless you count MRSA and C. diff. But know essentially what the terms, as far as if I say who is the host here and what is the process of infection versus contagious, right? And so specifically, if I say, the reason I make this distinction is a lot of times people will confuse something being contagious from an infection. If I cut my finger and I get an infection there, right, it's a little different than me somehow being able to give that to you. That would be a description of something being contagious. So again, even though we're going to be spending some time talking about infectious diseases, there's all kinds of diseases. I don't have any test questions that are like, what kind of disease is this? I'm just mostly trying to point out the fact that, or trying to kind of dismiss the fact that diseases either are or aren't only infectious. Diabetes is a disease process we talked about. Some of it comes from your genes, some of it comes from your lifestyle, some of it comes from your cargo pants, whatever the case. Now, this is another vocab breakdown. Some words that are kind of, they appear in the chapter and they're commonly or confused, I should say. Put pretty simply, endemic and epidemic are probably where we want to start. To say that we're a little more familiar with the language of epidemic. The big difference between something that's endemic is just the sudden significant increase, really. Like the flu virus might be endemic because it comes through every year in America. But it wouldn't be an epidemic unless it was a specific kind or just suddenly taking over in a big spooky way. So really, it's just a question of like, okay, do we know what's coming around this time of year? Or is this a surprise? COVID was a surprise, right? Then the question becomes, Does it stay in this area or is it spreading big time? In which case, if we've got global presence, Santa has been very busy. No, it means essentially that the virus is largely all over the world. This is a breakdown of why you die from infectious disease processes. Put pretty simple, despite my high school track record, it's not that difficult to reproduce. Viruses, however, largely need to commandeer some other ship to do so. And so, in a certain sense, all these different viruses and all these different names of these viruses are largely just descriptions of the cells they attack, in a sense. Something like pneumonia is, I'm sure, has a sciencey name as long as my arm, colloquially known as pneumonia. But really, when we say that word, what we're trying to conjure up is the idea of a virus that doesn't attack your finger or your hair or your liver. It goes specifically to your lung cells. If you can kind of zoom out and let's say, okay, picture a virus that's the size of a textbook, maybe that's the virus. And kind of what it does, like pneumonia will go in, rip out a lung, and then just sit in its spot. That's kind of on a large, silly scale what a virus is doing. The only part I'm leaving out is the hijacking and the reproduction. So obviously a virus isn't just replacing the entire lung, or at least not as at first. It goes in as a single cell, takes over another single cell, and then reproduces, taking over the whole structure. And we're going to talk about our allergic response, and we're going to talk about our immune system response. If bacteria and other things hijack cells, I don't know it, or I don't know that. I know viruses do for sure. Now, what's super interesting, I think, or whether it's interesting or not, what's super important to know is that your body's response to these viruses is just scorched earth. Essentially, what they're doing is they're sending an immune response to an area, carving out a host of flesh, and just rebuilding from scratch, basically, right? And so if I get you ever get those, what do you call them? They're not thorns, splinters. You get a splinter so deep, couldn't dig it out. You're just like, I'll just leave it. And in like 3 days, it gets infected and you just squeeze it out. Right? I mean, essentially what's happening is your body is just bombing the area, right? And sending all kinds of white blood cells there to create this little pocket, and pus builds up and then it slides out and makes a gross noise you can put on YouTube, right? Super gross. I say this because I want to point to the fact that if you've got a person with isolated swelling or redness, inflammation, pain, these are signs of infection. Guy says, yeah, I don't know what's going on. My hand feels real funny, and you get there and it barely fits in his glove anymore, right? The body is essentially sending fluid there and cells there to attack all of the various bacteria, viruses, whatever, and then return. So it's a very common sign. In a certain sense, this is largely how we should consider our vascular space, like our blood vessels, with erythrocytes pretty simply and flowing through it with ease. And as our body gets various viral loads and we start building up an immune response and an inflammatory response, we start filling it with other things for sure, right? If you remember a discussion about DIC, a lot of this is just oversaturation of clots, and then we can't get clots where we need. And so you've heard this term, I think inappropriately is ascribed to diabetes, but the solution to pollution is dilution, right? I mean, essentially what we're saying is, look, if you should have a clean running system here with just erythrocytes running down, and all of a sudden you've got viral load, and you've got, your blood sending all of this material to that area, it has a way of overwhelming things. If I said, hey, could you die from a splinter in the finger? The answer would be, well, it's unlikely, but it's certainly possible. If the if the inflammation spreads and the infection goes around, I think that's why I said inspection, because he's got a little looking guys. Right, and so this is what I was saying as far as the ways we would expect, or the things we would expect to see. Ooh, don't want to get into SIRS right now. I remember getting a call once because there was a fella who's paraplegic, right? So the lower half didn't work. He was in a wheelchair. He said, I hate to call you out here, but I just need someone to help me change socks. Couldn't afford the home care nurse anymore, and I can't get the socks off. I said, no problem, dude. Easiest call I run all day. I go down there, I grab one of his socks, and when I pulled, a bunch of his skin came, and all this brown liquid poured all over my boots. And I was like, buddy, you've got a serious infection, right? Fluid had been rushing to that area to fix some issue. It had becoming necrotized. His skin was sloughing off. I mean, I just put the sock back on. I was like, oh, no. No, I did not. But it was funny how much I had to convince him to go to the hospital. I was like, no, it turned out to be quite a serious call. Yeah, he started lines, running fluid. His BP was low. I mean, he was septic, you know. He took so much convincing to go to the hospital too. If you don't know already, it's funny how usually the more a person needs to go to the hospital, the less they want to. And the less they need to go, the more they want to. It seems pretty inverse proportionally. But in any case, this guy was having a serious infection. And so he was like, nah, dude, don't worry about that. It's fine. I said, it's not fine. You definitely are going to lose a foot here, then your leg, then your whole life. One thing we need to be familiar with is our SIRS criteria. And then as we progress, you got a bunch of test questions coming that are essentially, here's this person's presentation, including vital signs. At what stage of infection should you suspect? Now, I remember SIRS as the 4 T's. And I'm 100% sure I didn't invent this, but I never hear anybody else talk about it, and it's the easiest way I can think of to remember SIRS criteria. Tachycardia, pay special attention here. What is tachycardia? Define or give me a number that's a tachycardic adult. At what point does a heart rate become tachycardic? 101, which means that if you are, now tachycardia here is a little bit of a misnomer, but it is a good memory trick. I'm not saying, it is a person with a heart rate of 92, do they qualify for SIRS criteria? Yes, they do, because it's over 90, not because it's technically falling outside of the normal heart range. So be careful. Tachypnea, thankfully, fits neatly inside. Temperature, I can only remember Celsius, and then the high end of Fahrenheit. I can never seem to remember what the low end of Fahrenheit is, or what the equivalent of 36 is. So there's a formula, 2 point something or some, I don't know, whatever it is. Now, you won't have anything other than acknowledging total leukocyte count. It's just not something you can test in the field, but that is the 4th part.
So with like a test question, we would just be looking for the first 3.
We'll go into all this stuff a little bit more, so don't worry too much about it. But a test question will be something like, you've got a guy that feels bad, looks like he has an infection or doesn't, which is important. Because like allergic reaction, you're not just giving epi out to every low blood pressure. We want to have a suspicion that there's an infection in the first place for this guy. His vital signs are heart rate of 110, respiratory rate of 22. What should you suspect? And you're on the way through inflammatory process, no doubt. I've got a suspicion of an infection. I now have 2 SIRS criteria. The question becomes, what is his blood pressure? We'll talk about that in a second. Like we have said before, we might be talking about a hypoperfusing condition, but I always find it best to remember that you don't get a name in shock until you become hypotensive. When you're on the down big time, arguably before irreversible. So let's kind of walk through some language here. SIRS criteria is a list of symptoms. It's a syndrome of 4 specific things. Let me see some of my animations goofed up here. Now, you might have a SIRS criteria if your heart rate is over 90. That's one SIRS criteria. But we wouldn't suspect sepsis until you had 2 or more. Well, you might suspect sepsis, but you're not septic. So this is a person essentially, let's say I get a thorn in my finger or a splinter. It swells up, gets warm, red, hot to the touch. Do I suspect an infection? Sure. Am I septic? Do I have sepsis? Well, that depends. Do you have 2 or more of the SIRS criteria with a suspected infection? Well, I definitely suspect an infection. The question would be, well, what is his heart rate? What is his respiratory rate? What is his temperature? And then we'll take him to the hospital so they can check his white cell count. White cells are, of course, fighting infection. When would we say, let me say this, I got a person with a heart rate of 94. They've got an abscess tooth. They've got a respiratory rate of 22. Are they possibly septic? We've got the abscess tooth. We've got 2 criteria of SIRS. That means we'll call this person septic. How would you know if they're in septic shock? Hypotension. Now, specifically, you're going to get a bunch of questions that are a person who has no suspicion of infection, but has all the SIRS criteria. A man is running up and down on the field practicing for some sport. His heart rate is up, his temperature is up, respiratory rate is up. He's not SIRS criteria because there's no suspicion of infection. He's just working hard, right? You did something, it didn't help. Like status asthmaticus is a condition where I gave albuterol to a patient in an asthma attack. They're still having an asthma attack. They are now refractory to my albuterol treatment. And so in this case, septic shock is often associated with refractory hypotension. I guess I would say we can just leave that part off. Refractory. We can leave the refractory part off. When you go into AEMT, that will be a little nuanced, but we'll just say, look, if you've got a guy that's positive for 2 or more SIRS criteria and is hypotension, whether he drank water or a medic gave him IV fluid, we'll just call it shock, septic shock, because he's hypotensive. MODS is the stage after. Multiple organ dysfunction syndrome. It's not just a way of saying, man, I'm having a hard time and now a bunch of my organs are having a hard time. It is a cascade event. The numbers on the left are the mortality. We'll start at death, which is generally 100% lethal. Yeah.
Septic's really almost half.
Yeah. Well, so therein lies the crux, refractory. Yeah. If your blood pressure drops and you're septic, then I don't know what the mortality is, but it's probably substantially lower if I can give fluid and fix it. But if you're not responding to fluid, you die half the time. Yeah, and so I think one of the things that happens a lot in EMS education is we kind of sometimes, at one point I'd like to include more patient videos somehow. Like I almost wish I could have gone back in time and somehow violated HIPAA in the biggest ways and just been like, oh, here's a septic person, let's take a video real quick. Because, yeah, body cam. Because it's just so tricky. Because here I am, I'm like, yeah, septic and then septic shock. And you're like, whoa, man, that's quite a jump. And I'm like, yeah, but if I could show you what those people look like, you'd be like, wow, that guy's going to die 100% of the time. They are usually super duper sick. You don't. Yes, they get worse after they go into septic shock. This essentially, if you want to count, sepsis and SIRS criteria are often indications of compensation, right? Tachycardia, tachypnea, these kind of things. Decompensation occurs in septic shock. Refractory is essentially MODS, or beyond that point. But just like you couldn't tell in the field the difference between decompensation and irreversible or refractory, you can't tell the difference between septic shock and MODS. But But again, it's a cascade event. This is, your liver fails, then your kidney fails, and all this different stuff. So once that starts happening, you rarely come back. But again, this is talking about people in advanced stages. I just want to point out as well, the language here is used very confusingly interchangeably. We'll say things, huh? Oh, I think he's septic. I think he's septic. When somebody is septic, they are not implying that their blood pressure is low. That is specifically septic shock. So be somewhat careful there. The terms, I think this is sepsis. Well, if I said to you, hey, this person is septic, I'm explicitly saying that I suspect the infection is getting really bad, and I'm implying that their blood pressure is fine. But people use it interchangeably. Now we're looking at 2 injuries here, and on the left, we have a very clean injury. We're super happy to see that, and it's probably recent. Whereas on the right, we have one we're less happy to see. Now, incidentally, this one is being treated. Do you see that little piece of tissue or gauze hanging out? A lot of times what they'll do is because all the tissue in the area is dying, some patients are just, it's like this giant abscess in there. And so they'll pack it full of gauze and then have to pull that gauze out every couple of hours or every day, put clean gauze in while the body restores and heals itself. But if you have diabetes or high blood pressure, that may take years. So I've definitely been to a couple of calls where the guy's like, I don't need to go to the hospital necessarily. I just have a big ulcer back here. Would you mind just pulling all the gauze out and putting it back in? Super gross. And I wouldn't even advise necessarily that he went to the hospital unless I started seeing surge criteria, For him, it may be normal to have a gaping, weird hole in the back of it, It's not great, but it might be how we treat it. So just remember, I'm not looking for just bleeding stuff. Do you see how cranky that looks, right? Red and inflamed and swollen. Be mindful of those things. Now, we have to be somewhat careful here. This is getting back to a time when, I've really started to dial in the idea that you should identify common symptoms and then unique symptoms, but this is really where I kind of stumbled on this the first time. I used to have slides that were like, hey, here are all the symptoms, and it reads like a Cymbalta ad or something like that, where it's just like, hey, this can cause like nausea, vomiting, headache, weakness, dizziness, anal leakage, pregnancy. Like you're just like, what? Like just innumerable amount of symptoms can occur when you do anything, basically. And so we're not looking to learn these diseases to say, okay, one of these is that, well, yes, they can all cause headache, no doubt, but it's not specifically indicative of any of them unless you narrow it down further, right? And so having thoughts of these generic symptoms gets us in the wheelhouse, but we need to be specific. Now, we talked in part about how these viruses hijack your cells. It will become super important to know that a lot of these are transmitted by droplets. Does a surgical mask protect you from droplets? No, it does not. We just jumped from flu to HIV. Just boom. No continuity at all. Why would a person who has a flu virus be dehydrated? Yeah, if they were in hypovolemic shock, but even long before that, right? To virus, right? That's essentially how we fix things, is it's moving fluid around, moving fluid around. It's in a hypermetabolic state. The body is trying to process its sugar and resources to fix its situation, right? Now, HIV, unlike flu, really different effect. We don't need to go into the super specifics of how they work. The big distinction here is, like I said, if a flu goes into your lung cells and takes over your lung, that's not good. But your body can fight it. Part of what makes HIV so dangerous is it doesn't take over your lung cells, it takes over the cells that fight viruses, essentially. And once you've kind of hijacked that plane, the whole thing might go down. So this literally is attacking a virus that implants itself in your immune system. The number one type of contact between the two is contracting it, is sexual contact. Yes, you can get it from blood. Yes, you can get it from breastfeeding and the like, but not specifically from saliva or tears. Yeah.
So that's, the kid would get it, you know, the breastfeeding mother.
Good. Yeah.
That's what the.
Yep. Yeah. Not recommended unless it is required. Now, I would be a little careful here. What I don't want you to think is be like, oh, he just spit on me. I can't get HIV. Well, one of the number one sources of blood in the world is people's teeth. So, saliva, if it has blood in it, could be a different issue. But this is why essentially we've seen this a major uptick in the specifically male homosexual population, because based on their sexual practices, essentially, not only is it sexual contact, but it also can cause abrasions. And so they're at explicit or a specifically high likelihood to get it. The big giveaways for this, like why you would expect somebody to have HIV, though I will admit, it's funny, even since I started this, I think that the treatment for it has gotten so much better and manageable in many ways. Weight loss is a big one. How thin it makes you as it takes over.
So if you have HIV, at some point you just become completely immunocompromised.
Well, admittedly now, I think that the life expectancy is substantially better, and I don't even know if it's fair to say that you just get AIDS eventually. It certainly used to be. AIDS, of course, being just a umbrella term for a host of symptoms that usually come from it, but it's often managed now with the right treatment. Never got AIDS, HIV, no AIDS, Magic Johnson. Yeah, maybe. Maybe. I don't know. A lot of times when I see patients who are overcome with HIV, who have AIDS and the like, are often homeless people that just don't have access to meds and aren't being effectively treated. Now, one thing that I suppose I want to point out too as well is I think in a lot of what do I call it? Like paramilitary circles, like fire or police and stuff, they'll use the code 200 as kind of a way of communicating that a person has HIV. It's just like doing a 12 lead or assessing a woman's chest. Like we make these, or asking about a period, we make these things weird, not them. Like there are so many times I've walked on scene and they're just like, hey man, they're like, hey, code 200, dude. It's a code 200. And I'm like, okay. Thank you. I didn't plan on playing with his bloody wound in my mouth or anything. I'm like, I should be all right. I appreciate that. So I know that the people are largely trying to protect each other, I suppose, but like, he's got HIV because he told you so. So you're not really surprising him by telling me about it. And so usually how I'll communicate this to a nurse is I'll just layer it in as part of the normal assessment. Yes, I want them to know that he has a virus, but I would also let her know that if he had a lung virus or a hepatitis, like these are all contractable things. And so we just handle it similarly. I don't treat it like it's an atom bomb in my hands. And so I'll talk to a nurse and I'll say, hey, this is Chris. Chris is complaining of weakness. Now, he does have a history of high blood pressure and HIV, but he's not taking medications for either. He wanted to come in today to get checked out. That's it. I didn't need to give some secret squirrel handshake or be real careful. But again, largely, as long as I'm not having sex with this guy, and I rarely did, it was probably not an issue in the first place. So I just think that we could probably take the fangs out of that quite a bit once we've kind of discovered how it's largely transmitted. Now, the thinness, the weakness is definitely something that's going to be pointing me towards the possibility of HIV and specifically AIDS in that case. But another one is PPE, or perhaps we should never say PPE, but the pruritic papillary eruption or red bumps. Now, the hard part is we've got all of these different red bumps a person can get. And if you can get 10 different interpretations about a 12 lead when you talk to 5 different medics, you can definitely get different interpretations when it comes to dermatological assessment. So some of these are measles, some of them are chicken pox, some of them are the papillary eruptions. I don't remember which ones they were, and I didn't trust what the description was when I Googled the pictures in the first place. So all I mean to say is that if a guy's got a sudden weight loss and has red bumps everywhere, I'm strongly suspecting a contraction of HIV. weight loss is often associated with tuberculosis, but PPE is not. And so those red bumps would point me more towards an HIV contraction and away from a tuberculosis contraction.
So are these common symptoms for HIV?
No, I wouldn't say so. In a certain sense, it's a little like I won't rule it out if it's not there, and it can be tricky even if it is to rule it in. But if a guy is like, I'm not so sure I've ever gone back to a hospital and discovered a dude had HIV. Like the nurse was like, whoa, he didn't know, and we just found it. Every patient I've ever had knew it full well because it was affecting them, and they went in to get evaluated. But again, if I had a fella that was homeless and it was thin and covered in red bumps, I probably would think either bed bugs or something like that first. Like it might actually take me a minute to get to this point. If he started talking about chronic headaches and malaise and sudden weight loss and stuff, I'm like, okay, I don't think a bug bit you, dude. I don't think that you're having a reaction to the thing you slept in. I think it's a virus. And I think these might be. Sure. So it means to feel bad. Like you ever got sick, and if I was like, hey, do you feel weak? And you're like, I guess I just feel that's malaise. Like sick. But the word sick can be a little ambiguous. I feel sick. Oh, like you're going to throw up? No. But it could be. So malaise is specifically the feeling bad. Feeling bad. Not pain, not explicitly weakness, just feeling bad. So I broke these out. You can find these on the resource tab on Blackboard, the disease cards. Admittedly, I haven't combed over them in the last probably year where I got much better at kind of isolating information. So there might be a bit of an abundance here. I did my best to kind of bold things I thought were highly specific. But you'll have test questions essentially that will say, you've got a patient who feels bad, has a headache, and red bumps everywhere with sudden weight loss. Is it HIV, TB, pneumonia? I'm like, well, didn't say anything about respiratory pattern, didn't say anything about hemoptysis. Those red bumps are highly specific in this context. I thought this was interesting. I went and looked it up as far as needle sticks. I've always felt like my wife and I, when we were, what do I want to say? We weren't trying to get pregnant, but we weren't not trying. Like it's a little like, oh man, we got pregnant. I don't know what happened. I'm like, well, were you having sex? They're like, yeah. I'm like, well, were you using protection? I'm like, and what? I don't know how to have a baby if it's not by having unprotected sex. So again, it's not that we were trying hard, but we were trying. And after 2 years, we weren't pregnant, so we went in for an adoption. And because we had a buddy that went over to Malawi, and he was like, hey, I got a bunch of kids over here that need parents. Would you want one? I was like, sure. And they're like, also, they come with HIV. And I was like, yeah, okay. So we did a bunch of different research on what it was exactly and how contractable it was. My grandma, I remember saying things like, how are you going to bathe it? Like, how would you bathe it? And I was like, in the water with some soap. And she was like, but you might get HIV. And I'm like, Grandma, no. So you're far less at risk than when we once thought. And honestly, the more I say this, the more I'm like, I'm probably only maybe talking to a couple of you here that grew up in the 90s, but we grew up very afraid of it. Anyway, CDC says that cut exposure HIV needles essentially 0.3% chance. Now, it's certainly not a risk I'm willing to take or test, but I can remember watching an interview with a guy who isolated the HIV virus. A French guy, I forgot his name. They had asked him, are you worried about needle sticks? And he said something like, you could get stuck with a needle that was full of HIV, and your risk is infinitesimally low of contracting it. So again, sexual contact is one of the big ones. Hepatitis is absolutely, if you said, hey, out of all the viral discussions, out of all the infectious diseases, what's the one I need to know the most? You have to be able to differentiate and recognize signs of hepatitis, faux shout. Now, hepatitis in the name is just itis, which means what? Inflammation. And hepa is of the liver. And so really hepatitis just means inflammation of the liver. The reason I make that distinction is because the virus or viruses are hepatitis A, B, C, D, but it doesn't necessarily mean that you have inflammation of the liver. And more to the point, you can get hepatitis from things that are not viruses, like alcohol or liver failure from acetaminophen overdose, Tylenol. So, like as we were talking before with the parenchyma and various influenza things, respiratory viruses are attacking respiratory processes and taking them over. These are taking over largely a hijacking of the liver cells. I've definitely seen test questions, registry questions that talk about, it'll just plain and simple, it'll say, hepatitis B can live outside of the body for how many days? 7, 21, 14, 30, right? Now, I remember this because hepatitis B is brief. Hepatitis C lasts for 21, but hepatitis B is brief. It's less time. If that works for you, you're welcome to use it. Patent pending, patent pending, patent pending, patent pending. So essentially what this means is that we have to be particularly careful. This will go into a discussion a little bit about like cleaning versus sanitizing versus sterilization and stuff, that if I see somebody's hepatitis blood on the stretcher and I wipe it with soap and water, I might take the blood and then leave the virus. It's especially important to know that if that was hepatitis C, it might be on that stretcher for the better part of a month. So think about that as you go to eat your sandwiches off the ambulance floors. Okay? Maybe it's something you should start to do less. Now, we do have to talk about this part right here, which is liver dysfunction. I think sometimes people get these terminologies confused. If you have hepatitis, you don't necessarily have liver failure or cirrhosis. These are kind of progressive states. So you might have hepatitis and have chronic liver issues, but cirrhosis specifically means scarring. Now, I've never heard of cirrhosis affect anything outside of the liver, but it's worth noting that everywhere you hear the word cirrhosis, they will say of the liver. So my guess is that cirrhosis is more of a generic term. But again, if I had me a tall glass of hepatitis B right now, I wouldn't just have cirrhosis. And it might even be a while. It might be years before I get even liver inflammation. But as the liver kind of degrades, as the cells take over, as scarring develops, cirrhosis is the scarring, and it will degrade the liver's function. Okay?
She's scarring of the liver.
Well, cirrhosis is definitely scarring, but again, I always hear it described as, well, the patient has cirrhosis of the liver, which tells me you can get cirrhosis other places, which I've never heard of, but I think it's fair to say cirrhosis means scarring of the liver. It's, it's not like I took a sip of hepatitis, now I have scarring of the liver, but that's where that train stops. Now, we've used a term a little bit here called about hepatomegaly, an enlarged liver. What did we talk about before? If I get a splinter in my finger, how does the body try to fight that?
Kills the cells.
Nukes it out, sends fluid rushing to the area, it swells. Okay, that's what's happening with your liver. If you've got hepatitis B on a long timeline, fluid will rush to that liver, your liver will become engorged, less effective, it'll start scarring, and it'll scale you down. Okay? Here's a little maybe more realistic sense. Now, your liver in part affects a lot of different things, and one of the things it does well, or is supposed to do, is break down blood effectively, and if it can't, it'll stay in your system. Bilirubin is particularly dark colored. It's a byproduct of the breakdown of blood. Generally speaking, here's what you should think when you see people with yellowed skin, jaundice of the skin, or the sclera, the eyes. You think first liver, then kidney. Almeida hates eyeballs, which is weird because she's got two of them. And they're not nearly as yellow. So what I'm getting at here is if your patient is jaundiced, I want you to think there's a liver failure issue. If it's not liver, then it's what? Kidney. Because the liver might be causing, inappropriately handling bilirubin so it can't break it up effectively. But even if the liver was doing its job, the kidney might not be excreting it. So again, if you said, hey, I'm going to get a question on jaundice on the registry, what do you think it's going to be? I'm going to say it's going to be a liver issue. And you said, well, what if it's not that? I said, then it's going to be a kidney issue. There's not a whole lot that does that to people's skin or sclera that isn't jaundice. Yeah, it's just the coloration of bilirubin as part of your body and the blood breakdown is supposed to break it all the way down and then excrete it. Well, if your liver isn't able to do its job, then bilirubin's going to back up. Or even if it can and your urine isn't outputting it, then it'll back up and you'll be yellow. So it is pretty common. Well, pretty common. Several times, I suppose, in my career have I been like, "Oh, okay, how are you feeling today?" "I don't know, really, really weak." And I'm like, "Oh, okay. When did you find out that your liver was degraded?" And they're like, "Never." I'm like, "Oh, spoiler alert," is I guess what I should have said. So be a little careful there. I've definitely accidentally surprised a few patients with this. I would just lead into it. History of head problems, lung problems. You got any liver issues? No, none at all. Great. Well, you do now. Let's go to the hospital. Now, it can be normal for children to be born jaundiced. Why? Well, because their bodies suck at being alive. Their liver function is only really just started to crop up, and so they're not good at excreting and destroying the bilirubin. So they can be yellow. They put them under a little lamp for a while, and they're fine. So don't be too distracted there if we get into the part where we talk about babies, OB, and then we've got jaundiced kids. It may be a normal situation. Graham? I don't. If you said to me, do sickle cell patients present with jaundice? I would say sickle cell patients with liver dysfunction do. And so if there's an association that deals with jaundice that isn't liver or kidney, I don't know it, but I'll bet you if it's common that sickle cell patients have jaundice eyes, it is because the sickle cell is goofing up their organs. But in short, I don't know.
This is associated with the HIV, or is this just like with
Hepatitis. HIV does not directly affect your liver.
because HIV is inflammation of the liver, essentially. So
HIV is not inflammation of the liver. HIV is essentially an infection.
I'm sorry. I'm talking about
Okay. What do you want to talk about?
does that go with hepatitis, or is that like a different?
Are you talking, does cirrhosis go with hepatitis?
All that stuff? Are these like signs and symptoms of hepatitis?
So pneumonia is a virus that infects your what? Your lungs, right? Hepatitis is a virus, or can be a virus, that affects your liver.
Oh, okay.
There you go.
Okay, great. Thank you. Sorry, slow moment.
That's all right. That's a lot. I don't think I've ever seen so many yawns in one class. It must have been a... But you love ascites. We're about to perk up. Been waiting all year for this. So one of these patients has ascites, the other has a parasite. Now, my suspicion is the one on the left has a baby, and the one on the right is hepatomegaly or ascites. But again, this abdomen is incredibly swollen. That's what ascites means, A-S-C-I.
Is that why you? This is gonna sound real stupid, but is that like when you see like men and their bellies are like super big and they?
No, ascites is a pathological condition. Like if you said, is diaphoresis just sweating? I'd say, no. Diaphoresis is pathological sweating. You're supposed to sweat when your adrenergic nervous system is helping you chase down a baseball, right? So this, as you can see, he almost looks like thin everywhere, but not there. Like that is fluid collecting in his peritoneal space. Yeah, they drain it. But what my suspicion is that his liver function is decreased. And so he's not processing his fluid well. Fluid is building up around the liver and it's going into his abdomen. Now, I ask patients this all the time. I'll see a situation like this, and it gets difficult if they are overweight because now it all kind of looks the same. It's not particularly large. And I'll just ask, I'll say, hey, your belly looks distended to me. When you take a look, does it look completely normal to you? And they're like, oh, am I fat? Is that what you mean? And I'm like, that is not what I mean. Like, did your abdomen start looking like this like in the last couple of days, or just has it always, right? It's a sign of liver failure. Again, and I got my little bottle here just to remember. It's interesting to talk about overdosing. I don't know what it is with blonde white girls, but they love ODing on Tylenol. And I don't... I don't know if it's that common because they are like, oh, it's an over-the-counter medication. It's not that dangerous. I can kind of do a crawl for help. Or if it's just whatever's readily... No. I'm saying that they use it to kill themselves. That they overdose. No, it does not get you high. No, you're okay. Essentially, and so what I try to, so when I talk to people that overdose on Tylenol, certainly I always ask this question when people take too much medicine. I say, hey, you took way too much medicine today. Was it to feel better or to feel worse? It's like the foundation of suicidal ideation. Because there are people who overdose and stop breathing on their pain meds, but they didn't want to die. They were just tired of being in pain. I wanted to feel better. I took a bunch. It was too much. So I just ask them that simple question. Hey, did you take all this to feel better or feel worse? Because those are very different pathways, right?
That doesn't change treatment. Is that just more for when we transfer care?
It lets me know if I'm dealing with a psychiatric emergency or an isolated physiological one. So I think there's a big difference. Like if Brandon right now said, hey, I just took 2 bottles of adult Tylenol, I would be like, oh, okay, well, let's check your vitals, make sure you're stable and all this different stuff. But also I got a question for you. Did you take that much because you wanted to feel better or worse? And if he was like, just feel bad, man, I'm like, okay, we need to go in. He's like, nah, I don't want to. I'm like, I really want you to, right? So it kind of helps me understand the situation better. Also, when I talk to people that overdose on Tylenol, I'll tell them this. I say, look, there are 2 conversations I really want to have with you. One is how you shouldn't kill yourself. But before we have that conversation, let's have a more important one. How if you're going to kill yourself, you do not do it with Tylenol. Because here's the problem. You will definitely die from an overdose of Tylenol that is enough to kill your liver. No. On the way to death, it's like somebody twisting a rusty knife in your abdomen until you beg for it. So usually I get those people to transport to the hospital, again, not by telling them about their death, but by telling them about what they're about to experience while still being alive. So I'm like, look, I'm not here to convince you specifically that you shouldn't kill yourself, or at least not yet. But you definitely should go so they can pump your stomach and give you an antidote for this, because you are going to wish you did something else to kill yourself later, I assure you, right? Truth is you can say that about any instance. If you caught a guy halfway down the Golden Gate Bridge, it is many times you can convince him of the same thing. Now, we have to differentiate types of hepatitis virus, not just hepatitis, but the viral hepatitis. I am almost sure you are not going to get any kind of questions about A or E. You will definitely have to differentiate B and C. But the easiest way I can remember this is CB is child. You can get C and B through childbirth. You can get B through the blood and breastfeeding. And then you get A and E from eating ass. No, I'm leaving it. It's vulgar, but it is a great way to remember it. I mean, largely you get A and E through the fecal-oral route. Not, oh, it very is. But I think it's fair. I mean, it's not even an intent to be humorous, just to remember. So you'll get questions like, how do you suppose these viruses can be transmitted? Well, if you ate it, or if it had poop in it. That's A and E usually. Now, I will say it's uncommon in the States for sure. You're getting this in third world countries where they don't have an FDA policing their food. They are raking something with animals nearby. It touches a thing, you eat it, you drink the water, you get the ick, these kind of things. Yeah.
Hepatitis can be cured, or is it like a lifelong thing?
Well, let's take a look here. I don't remember. So this will be largely what you need to kind of make the distinction between hepatitis B and C. With hepatitis C, antivirals cure 95% of patients. With hepatitis B, it's not curable, but vaccines can largely prevent a lot of this stuff. What's particularly tricky about hepatitis is they'll often call it the silent disease because you can live for years before it even starts to cause major issues or surface. And so, when you work for very long as an EMT, essentially people will be like, oh, aren't you scared of things like HIV? And you're like, not really, but hepatitis, maybe. It's way more common, way more contractible, and also can go for a long time without being detected. Now, one of the things I also wanted to point out is the term virulence. I put this picture here from the book. The book explicitly says that hepatitis B is both the most contagious and the most virulent. I have a test question that asks that directly. Which of the following is the most virulent? Virulence, however, is difficult to quantify. Essentially, virulence is a way of saying the likelihood that a person will catch the disease. Well, that can change based on a lot of things. Like, if there are no people in here with hepatitis B, then it's not particularly virulent because there's no way of contracting it. So I think that virulence is really a word that is a math problem. It is the contagiousness of the virus. It is the deadliness, perhaps. It is the popularity and proximity. So I think more than anything, don't overthink the word. Just know that B is the answer. I saw it on the registry.
Well, I'm just trying to get points for exams that I know.
I get it. All right. Take a quick break, and then we'll talk some meningitis.
My last call was an overdose. She tried to kill herself. You know what she did?
Can't not think of Dr. Pepper. I think meningitis.
I can't not think of lupus.
That's one as well. Lupus and meningitis.
There's another one too. I always forget the name of fibromyalgia. So if pneumonia is essentially a virus that infects and hijacks your lung tissue, and HIV is a virus that is infecting your immune response to reproduce itself, and hepatitis is a virus that's infecting your hepatocytes and hijacking them, your liver cells. Well, we can break it down. Erythrocyte, red blood cell. Leukocyte is a white cell. Myocyte is a muscle cell. Hepata is your liver. Cyte is a cell. Well, meningitis is inflammation of the meninges, which, if you remember from neuro, or I think it was from probably trauma, head and face, neck, spine, your brain and spinal cord are surrounded by meninges. And so this is a virus that will affect, or bacteria incidentally, that will affect those areas. One of the most common distinctions here that I'll admit I see more in testing than I ever did in the world is nuchal rigidity, Nuccal, nuchal. That means neck. That'll be whoa boy. Yeah, Mr. Simmons, say hi to the class. Let's get out of there quick. No, it's WebEx, and we were pretty intentional about putting work stuff on WebEx and fun stuff in Discord. But he and I are expressive people. It'll come through pretty quickly in both pictures and audio clips. Anyway, nuchal rigidity. Nuchal means neck. Rigidity means who knows. It's not uncommon for me to get on scene and a person be holding their neck and I'll be like, whoa, did you fall? Did a cartwheel not work out like you thought? No. Yee, meningitis maybe. Another common specific symptom of meningitis is what's called photosensitivity, or a sensitivity to light. Definitely. Bingo. And that's kind of the idea, is you'll walk in and be like, oh, it's dark in here. Do you want these lights on? They'll be like, no. Like, does it hurt your eyes? Yeah. Does it always hurt your eyes? Nah, just lately. You've been having headaches? A little bit. How's your neck feel? Real tight. Maybe. Do you have a fever? So on and so forth.
What's it called, the first thing you said?
Nuchal, maybe?
Yeah.
Nucc? I think so, with a B, or an N instead of a B. Rigidity. Rigid. Nuchal rigid. Neck is rigid. Now, there are two tests you need to know about distinguishing or discovering meningitis. One is called Kernig's and one is called Brudzinski's. Not to be confused with Babinski, which of course was the neurological assessment of the foot. This is how I remember, and well, this is how it's performed. The patient lays on their back and you either Kernig's to kick or Brudzinski's to bend, right? Kick, bend, KB. That's how I get through it. So you have the patient lay down. If they kick their leg up and feel back pain, it's a sign indicative of meningitis. Why would that be? It's got meninges on the spine, and that's why you're going to be moving it. Rudzinski's is a person with their bent legs, bent head, and it causing pain as well. That can be a sign of meningitis. Now ask me how many times I did this in the field. Why on earth would I ever do that? Like, you've got nuchal rigidity and photosensitivity? Lay on the ground. I'll see about that. I think so too. Look, if a good guy's not feeling very well and he's a little sensitive to light, I don't need him to put him on the floor and be very sure. We're just not going to play much kissy face. Maybe I'll throw in a mask and we'll call it good. That is not going to stop me from writing test questions on him. Yeah. Well, once you go take registry and come back, you'll say thanks.
So wait, Brzezinski's sign, do they get the back pain when they...
Back and neck. Yep.
Okay, back and neck.
Really, we're talking about, just largely manipulating any meninges. Kicking the leg will cause it. Bending the head will cause it in the neck. Now, you have to be particularly careful here. Roman. Yep.
This might sound dumb, but how do you differentiate that from migraine and headache?
No, that's what we were talking about earlier. The question was, if somebody's sensitive to light and has a headache, how would I differentiate it from just a simple migraine, right? Or how might you differentiate it from a stroke, right? I mean, a flu can have a headache, right? And sensitivity to light. Well, that's where Brzezinski's and Koenig's sign come into play, right? That's where a fever would come into play. A migraine isn't going to present with a fever, whereas a meningitis and inflammation of the meninges will. I got sensitivity to light, I have a headache, and also a tympanic temperature of 102. Is that just a migraine? No. That guy's got an infection somewhere, and it's probably in his meninges. That's why he's got the photosensitivity. Yeah, you'll have a worse one with bacterial probably. Because Brzezinski's. Yeah, because they're just inflammation of the meninges. All they're really telling you is that this guy's meninges might be goofed up. And if that's the case, we suspect meningitis, inflammation of the meninges. Due to severity. Now, will you know whether it's virus or bacterial? No, you won't. But the worse off a patient is, the more suspicious that it is bacterial. Because bacterial is more deadly and it is more contagious. The only thing that I know to separate, if you said you've got a person with meningitis and you're sure that it's bacterial, how do you know? The rash. There's a petechial rash that comes with bacterial meningitis that is not seen with a viral. Well, as far as pre-hospital treatment, we're managing symptoms because, yeah. I mean, their chances are they will be worse off with bacterial, but it depends at what stage they're in either case. But it can be fatal, and that's worth noting. Seizures can be common. Hopefully it doesn't surprise you to learn that if you have inflammation around your brain pan, it can lead to seizures. Here's what that petechial rash might look like. Now, as far as, are these actual meningeal bacterial I have no idea. Here's some red bumps. I know that's what the image was captioned. I don't know if it's true. MRSA. Lord have MRSA. Now, one of the common misconceptions about MRSA in general is that everybody's kind of got MRSA on them at all times. No. It's not uncommon to have a staph on you, Staphylococcus specifically. MRSA is a type of staph. It's a much more powerful and stronger and problematic, but it's far more rare to just have, if you said, oh, everybody's got MRSA floating around on them at all times, I would say that is so mathematically untrue. But really, your skin does a good job processing or keeping out all of these Staphylococcus viruses, MRSA or not. Dude, MRSA is a rat eating a hole in your skin. Like, if I see how this looks over here, A guy might say, I don't know if I got bit by a bug or what. And I'm like, maybe, dude. Like, if you got bit by a bug a while ago and it's like that, I know it's abscessed. I know you got a major issue. Dude, it is. Dude, what happens when they get some... Dude, what they do to fix that is they take them a little wooden medical spoon and they carve a hole out of you. That is a fist-sized abscess there, I can assure you. I had a buddy that had it. He was a wrestler. Why are wrestlers more likely to get staphylococcus? Because they're weak. No, just kidding. That one was for Jack. Well, because they're rolling around together, as boys do, right? On the mat where it can stay and live. But again, it's not having staph on your skin that's an issue. It's it getting through the skin. So you get this little cut somewhere. All of a sudden, the virus can essentially get, or the staphylococcus can get past your skin and then infect you. I had a... No, he definitely had a cut right there, and then the staphylococcus got in it. I'm so glad you asked. That's part of the reason I put it on there and underlined it. It means they invented it at the hospital. Well, invented is the wrong word. A nosocomial infection is not one you get at home. It's one you got at the hospital.
Someone contracted in the hospital.
Yeah, and so MRSA is common in wrestling and in the hospital because that's where all the people are. It is also where the people with injuries are, in the hospital. So nosocomial means you contracted it in the hospital, and MRSA is very common. So is, well, we'll just leave it at that for now. Nosocomial, caught it in the hospital. I had a buddy that had MRSA on his arm. He was like, when I went in there, man, they just took this, like, looked like a tongue depressor, and they just jammed it in there and swirled it around, and all the goop came out, and then he... No. Here's a fella. Now, we are actually very happy to see this injury. It's so clean. It's not red, and it's not infected, I should say. It's not inflamed. No. Mm-mm. He's got a skull you'd see first.
I mean, I don't know what that means.
Yeah. Remember when I said IM injections have to be about an inch long? Like, you look at my arm and you're, I mean, well, maybe not my arm because it's probably pretty clear. There's a lot of muscle tissue there. But in many cases, you're looking at arms and you're just like, dude, I mean, I'm touching a bone. And I'm like, wait until you're out there in the world seeing people split open. And you're just like, well, I can put my whole hand in there before I touch the bone. You know what I mean? So, no, this is just a guy with a lot of adipose tissue and the like. And that's just a whole, we have just probably seeing the skull there. Sebastian? Yeah, that's what it looks like. So on the left is the before, and on the right is after, other than it's a different body part. They went in there, scooped out all the bad stuff, and they're like, there you go, head. Go ahead and fix it.
He can heal like that?
Yeah, probably. He'll have a nasty scar. I would probably put a, what do you call it? Or like a fake eye as it heals up around it. Or maybe like a tooth. Yeah. Anyway. Methylene resistant is the big thing. If you get MRSA, it is super tough because it's especially resistant to the thing we use to kill it, which is a methylene-based antibiotic. So that's what that means. I want to make time for our immunization. So we're just going to kind of hit the highlights here. We've talked about TB in the past. It's a virus of the lungs, associated big time with hemoptysis, blood coming out of your lungs, also night sweats, also sudden weight loss. Remembering that, of course, HIV is as well. HIV may come with PPV or is sexually transmitted, which can be helpful to differentiate. C. diff might be new. Has anybody had a conversation about C. diff in the field? Okay. Just a huge fan. Yeah, maybe. I don't know. C. diff, Clostridium difficile, essentially is a bacteria that people get. It causes a lot of diarrhea. You'll see these people with these orange fingies. I had to make it. You would not believe how little I had to pay this chick. But C. diff is basically what happens is when you contract this bacteria known as C. diff, and if you had C. diff right now, you would probably be okay because the good flora in your stomach can fight it, can kill it. Where people are getting this is largely when they're being treated with antibiotics for long periods of time, because the antibiotics are just nuking everything in there The C. diff wins out the fight, and all the things that would be fighting the C. diff are now dead from the antibiotics. So it is very common to see patients in nursing homes who are treated for chronic infections and the like with antibiotics to develop C. diff. Code 2 hundo. Couldn't wash hands, now is extinct. All right, there you go.
That was fun.
Yeah, little boo-boo, some woundage. Like to end every lab or lecture talking about Dookie. All right, let's talk immunology. Now be careful here. It always cracks me up. I don't talk about allergies in various levels, like mild, moderate, severe. You either are having an allergic reaction or are in anaphylaxis. Remember that when you approach that test question. Every time, like half the class is like, I'll call it moderate or whatever. And I'm like, what? Why?
Are we gonna have a test on these last 4 chapters?
It's going to be on your final. Yeah. Probably over the weekend I've made definitely a study guide, but probably like maybe a take-home quiz to kind of be like, hey, what do you got about allergies? Now, allergic reactions are specifically this response to an allergen, and it's typically a single system, like you just have a respiratory issue, a dermatological issue, a cardiac issue. It's largely isolated to single system. When it involves 2 or more systems, we'll call it anaphylaxis. Now, I hate defining it that way. You will hear it defined that way everywhere. Where I would like to define anaphylaxis is anything other than an isolated rash. That's how I'd like to define anaphylaxis. Because the more students are like, dang, well, his heart rate's a little up, and he kind of coughed. Ooh, I'm like, oh my goodness, give him epi. What are you doing, right? So I don't slice it that thin. Usually you'll hear the definition 2 or more body systems or isolated hypotension with a suspicion of allergic reaction. That's what you'll usually hear. If I think that this person could possibly be having an allergic reaction and isn't just isolated urticaria or a rash, I'm giving them epi, full send. Now, anaphylaxis can be life-threatening, and it may not look scary at all. We don't have time to show the video I wanted to, but it's a little girl in anaphylaxis. She gives herself her own EpiPen. She's just chilling at the doctor's office. And the doctor's like, okay, well, we're going to give you epinephrine here, sweetie, because it'd show you how to use it. This is your first profound allergic reaction. And she's like, okay. And she's like, click, ouch, whatever. And she goes through it. She looks chill as heck, but she's tachycardic and she has wheezing. Believe me when I'm saying, look, what's happening in anaphylaxis is widespread, systemic histamine being released and affecting your body. If we're sure it's affecting 2 things, you got a major life-threatening disease long before it ever looks like it. Now, sure, it may look like death. You come in, somebody's hypotensive from vasodilation. Yeah, okay, that one's easy. But it does not always have to. The amount of times I've given somebody epi where my partner's like, really? Epi for this guy? He's just chilling. I'm like, he coughed twice, plus he's got a red bump. Epi. So in summary, if we give epi largely for angioedema, that's a pretty dead giveaway. Now, angio means vessels and edema means fluid in the wrong place. And so technically angioedema means fluid buildup in a lot of places, but I can guarantee that when you hear the word, they're going to mean in your face, eyes, lips. My thought is always this. Look, if you can see swelling around the lips or in the face, you have no idea what's happening just behind it in the airway. Send epi. Send it. Don't chase allergic reactions. Let them chase you. If there's an allergen suspicion in hypotension, guy says, yeah, I was eating at this restaurant. Now I feel real dizzy. I check his blood pressure, 70/40. No other symptoms of any kind. No reasonable suspicion of that. I'm going to give him epi. Might be an allergic reaction. He's got low blood pressure. Plus he's at a restaurant. If you got difficulty breathing and cough, altered mental status, level of consciousness, and also got stung by a bee, bit by a snake, whatever the case is, brand new laundry, anything that's kind of getting on or in your body in that way that's causing these symptoms might be it. Now, epi isn't something largely we need to be afraid of. It's an endogenous chemical in most cases, meaning your body makes it. It can handle it pretty well. There is some concerns. We don't want to just give all people epi, especially if they've got coronary artery disease or they're over the age of 65, because giving people an adrenergic that speeds up their heart is not always good when your heart isn't great in the first place, or if you've got a bunch of atherosclerosis, right? So again, Mr. Fearon's, here's when I give epi is if you have anything other than an isolated rash, send it. That's my opinion. I mean, I'm going to have questions that are like, dude, do you know to give this guy epi? One will be because of a wheeze, one will be because of low blood pressure, one will be, but it'll just be a bunch of different reasons to give epi. Sometimes it's obvious. Guy will say something like, I ate something and then blah. Turn into a vampire, I guess. I don't know why I phrased it that way. Blah. It was blood. Or I got bit. There I was, petting my scorpion. He gave me a kiss. Hives, urticaria, or wheals, all synonymous for these various red bumps. Brr. Not R. That would be infection to pirate. Yeah, it's a very different. Scurvy. But know that this final is tricky because you'll get a guy with a bunch of red bumps, and the question will be, well, is it an allergic reaction, or is it perhaps an HIV viral infection? Is it MRSA? Is it chickenpox? What's not so obvious is when you're getting histamine being released all throughout your body and it's only affecting your cardiovascular system. Or a guy who has asthma is also now in anaphylaxis and he's like, it's just an asthma attack. And I'm like, no, dude, I don't think so. Now, it's not super important that you distinguish these terms. In fact, most of my career, I thought antigen was a thing on the outside, and when it went into your body, it became an allergen. That's not true. But let's look at it like this. If I get stung by a bee, proteins from that stinger are going to enter my body. Those are antigens. If they cause my body to have an allergic reaction, then those antigens are now called allergens. So maybe, Henry, you're allergic to tree nuts?
Tree nuts.
Tree nuts. Okay. So tree nuts will release antigens into your body, into yours and into mine, but they're only allergens for you because you are an inferior creature. No.
So like if you ate it, then that would be an allergen.
If you are reacting to it in an allergic reaction, that antigen is an allergen. But don't work too hard on slicing these things. I don't have questions that get you to know the difference between one or the other. But if you consider that like your blood is based, the descriptions of your blood are based on the antigens they possess, those aren't allergens.
And an antigen could also just be like something like a virus or proteins, right?
Yeah, it's a generic term. An allergen is an antigen that's causing an allergic reaction. I will use them in the lecture interchangeably. An antigen goes in, allergen, this and that, so just be cautious of that. Make sure that you know that there are many different routes at which these things can enter your body. You can eat a strawberry to cause an issue. You can step on a nail. There are many different routes. Breathe them. You can have an absorption. That's probably the trickiest one, I guess. Like somebody gets a chemical on a skin and they're like, oh, it's not burned, you're fine. I'm like, no, they're hypotensive. Why? Because they're allergic to the thing that touched their skin. Hymenoptera is a word we need to know. Not only will it impress chicks at the bar, but I have literally seen this monstrous word on the registry before. The only thing I can think of, I forget what it's called. It's like a phylum or a genus or a family of things. I don't know what the term is, but that's what Hymenoptera means. I saw it on the registry. It said, which of the following is in the Hymenoptera class or whatever, and it listed a bunch of different things. The only thing I can think of why they're highlighting that is because most people are like, yeah, bees sting you, you can get allergic. And in Michigan, it is, we don't know what ants are. We don't have, I mean, we got little black cute ants that no one minds. Not down here. You probably all know about spooky ants and them being a problem. But north of the Mason-Dixon line, it's not nearly so common to realize that ant bites can put you in anaphylaxis. So these are all types of that. So this will be a situation. Now this is tricky. In isolation, it's easy, right? Like if you're going to take one of my quizzes and a guy is like, oh, I'm dizzy and low blood pressure. You're like, but this is an immune response quiz. I've got an idea. But you aren't going to be doing these things on a quiz largely. You're going to be doing it on a final where all kinds of different things can be causing hypotension. Your practical might be a guy has called from a park bench feeling like maybe he's having an asthma attack, maybe he's dizzy, and you got to investigate a physical assessment, and you're like, hey, what's this bump? What are these red things? Right? Physical assessments are going to be the way to find out how to really attack these things. Because if a guy, let's say there's a scenario there where, a guy is feeling dizzy, through physical assessment, essentially, you find out, through a detailed assessment, you find out he's low blood pressure. And you're like, I don't know what this is. Dizzy, low blood pressure, let's give him epi. And it turns out he had a bleeding stomach ulcer. And you just sped his heart rate up with epi. And so now he's in hemorrhagic shock. So, the summary is essentially that we have to find a allergen suspicion. Now, you already know that if I was trying to give Narcan to some dude who was just actively popping opiates, that would not be conducive to his survival. So I'd be like, hey, please stop eating those while I give you Narcan, right? Or if I had a guy actively doing heroin, right? I'd be like, okay, we need to stop the delivery of this while I give the antidote. And so make sure that that's a very important part. Like I could absolutely see myself writing a practical where a guy got stung by a bee, and it's a huge issue if you don't scrape the stinger out. Take a back of a credit card or tongue depressor or anything kind of plastic with the ridge, and you just scrape that stinger out, because there might be a situation where you're just constantly giving epi, like, what the hell's going on? This guy's not getting any better. I'm like, he is constantly being injected with an allergen. You got to get it out of there. Antigen and allergen, like I said, we don't need to break those words down too much, but we do need to talk about antibodies. Now, if you took A and P, 2 is my guess, you'll remember a little bit about IgE, IgM, and stuff like that. Immunoglobulins, or antibodies. All you need to know is IgE. If I ask you which of the following antibodies anything in EMS, the answer is IgE. They all involve immune responses in different ways, but IgE is the one very specifically we're going to talk about. Or I guess I should say they all involve inflammatory processes. IgE is the one that involves immune. Okay, let's break down what exactly is happening in a primary response. This means there I was eating a strawberry. Turns out, just as strawberries would enter antigen proteins into all of our bodies, I react to it as an allergen. My body thinks that this harmless substance is going to kill it. And so what it does, like a shoplifter, it just takes a picture of that guy and it puts it on the wall of the body and says, hey, we're not going to do a whole lot right now, but if you ever see this guy again, you lose your freaking mind. That's basically what the immune response is. Now, in a technical sense, we have things called leukocytes, our white blood cells, not transporting hemoglobin, not transporting oxygen. They are our immune cells. B cells are the ones saying, oh, look at that. I saw that pesky little bee sting antigen. That guy's a problem. And it's the mast cells and the basophils that are losing their minds, that are degranulating and releasing histamine.
Do we know why the body overreacts to a substance sometimes?
We do not know why some people are. It is, I think I've heard it argued before that it was important in evolutionary processes. Like there were certain things you had to react like that to. And so those people, so I have a suspicion that it's just a bad gene, but I don't know. Now, I don't know that this is important, but once I heard that B cells is found in the blood, that's what your humors are, the liquids of your body, the humors. I just thought I would bring it up in case you see something like that, but B cells are in the blood, whereas T cells are inside the cells, affecting things. HIV virus affects the T cells. It takes it over. It makes the virus fight against, the immunized cells fight against themselves. So again, basically, I get stung by a bee. The B cells walking on by in the blood, and it's like, oh, I see you, little antigen. I'm going to call you an allergen and tell all my friends about you. And so basically, this process is called sensitization. Sensitization. There. It's a sensitive boy, right? Essentially, the B cells will see an antigen, say, no, not antigen, allergen. Take these IgE and send them everywhere. So the B cells are what are making IgE. The B cells are what are making antibodies. The B cells make the IgE, and where do they go? Well, they flow and they get attached to the mast cells and the basophils. B cell says, hey, I don't like the look of that guy. I'm going to take a picture of him called IgE and send it down the stream. Basophils and mast cells are like, oh, okay, I'll take a picture of that, make a copy for my friends. We see this guy, we're going to rough him up. With me so far? Okay. That essentially concludes the primary response. It's just sensitization, identifying an antigen as an allergen, saying, we see this guy again, it's going to be a problem. So sometimes those primary responses may be mild, and they may go unnoticed or may be confused as just a stomach bug or a headache or whatever the case is, because the body is not yet convinced or not capable yet of sending a global, powerful response that first time. Now, sometimes the first time can be pretty fast and pretty big, but again, in many cases, this primary response is just subtle. It's just a buildup. In the secondary response, this is where we're now experiencing an antigen, or specifically something labeled as an allergen, and this time we're ready for it, which sucks because allergic reaction is bad, but essentially, this is the mast cell and the basophil. This guy walks into the gas station. They look from him over to the wall, and they're like, isn't this the guy that the B cell was telling us about? Yeah. Well, let's have a problem, right? And so then the overreaction occurs. If your B cells are making antibodies, those antibodies are attaching to your basophils and mast cells. The only real difference, I think, between these two cells are their locations. Basophils in the blood, mast cells in the tissue. But they are like histamine grenades, these cells. Their job is to be like, that's the guy from the picture. That's that strawberry seed. And then they blow up and send histamine everywhere.
So they release histamine?
They degranulate, they break down and release histamine. So if you said, what is the value and purpose of mast cells and basophils? I'd say, well, they degranulate and they release histamine. The question could be, well, is that a problem? Well, it depends. Look, an allergic reaction, let me rephrase, an immune response where we have histamine release and these types of things, it can be helpful in fighting disease processes in a very normal way, for sure. An overreaction that causes widespread histamine release is essentially our anaphylactic and allergic reaction. So as you can see, these IgE are now attached to this cell here. Where did the IgE come from? Where did it go? Cotton Eye Joe. The B cells made them. Why did the B cells make IgE? Because it saw an antigen and then said, I think that's an allergen. I'm going to make IgE to combat it. Now, a lot of us are having a similar experience on a day-to-day as pollen comes in and all this kind of stuff. That's a normal process of inflammation, and we're okay with that. The overreaction is where it's an issue, right? So it sends out a million IgE. They all attach to these cells. It one day, like a key to a lock, that strawberry seed or bee sting comes by, it attaches it, and then the whole thing, like a histamine grenade, blows up and sends histamine everywhere. Now you can view this cell like the screaming child, like a piñata that drops all the candy, or a histamine grenade. But in any case, this is a cell breaking apart and sending histamine everywhere. The question is, what does histamine do? And you already know that, because you know what the signs and symptoms of allergic reactions are. Well, that's what histamine does. vasodilation, hypotension, bronchoconstriction, all these kind of things. Now, it should be said, even though I was only displaying histamine, it is not the only thing that comes out of that cell. Leukotrienes come out, prostaglandins come out, all kinds of stuff comes out of that piñata. If you remember the conversation about receptor sites, we have receptor sites all over our body that are receptive to different things. We've got mu receptors or opioid receptors, where when the fentanyl molecule goes by, it binds to that site, jingles the berry. I feel super good for a minute, then stop breathing because it does that too. We also have receptor sites where epi will roll by and connect to it, causing, if that receptor is in our heart, it causes our heart to speed up. If epi rolls by a receptor in our lungs, it will bind to that. Like wherever these receptors are being bound, they're getting an effect. Well, you've got histamine receptors all over your body. And when histamine is released, it will connect with them and cause an effect. So, make sure that you know that we basically have a primary response and a secondary response. And the number one thing that's happening in a primary response is just identifying the allergen, called sensitization. Lord. The secondary response is the profound overreaction. This is the manifested major histamine release. And reactions usually get worse. They can get better. I think someone was in this class saying they're not allergic to something anymore. The body can get better. I did some digging. We don't know why some people get better and why some just get worse, but what I mean specifically is their reactions. My experience is most people, every time they get exposed to something, they get a worse reaction. They develop more sensitization, more memory cells, and a greater reaction, which is why in the field you'll hear people say all the time, oh, you're allergic to that. Have you ever been intubated before? Like the clinician is trying to figure out, like, how bad does it get? But I never asked that question because I don't care how bad it got before. I care about what it's doing now. Now, you need to know these sites. You need to know alpha 1, beta 1, and beta 2 sites. These are receptor sites in various parts of your body waiting for stimulation. And they're part of the sympathetic nervous system, A1, B1, B2. You sunk my battleship. Right? Now, I don't have any alpha 1 receptors on my fingernails. I don't have any on my hair, which means when you hose me down with epi, nothing happens to my fingernails, nothing happens to my hair. But I have alpha 1 receptors on my vasculature. And so when you give me epi, it will flow into the alpha receptors in my vasculature and cause an effect.
Respond to epi.
Well, no. They will respond to adrenergic hormones like norepi and vasopressin. But they largely were referring to epi here. So again, alpha 1 receptors, stimulation of the alpha 1 causes vasoconstriction. Histamine binds to alpha 1 histamine receptors, causing vasodilation. It's like this. I eat a whole honeybee. I'm allergic to that spicy sky raisin. So my body degranulates basophils and mast cells and says histamine everywhere. Well, we have histamine receptors on my vasculature. We have histamine receptors on my vessels, my vasculature, and in my airway, and then to a lesser significant, in my stomach. We have H1 and H2 receptors. So again, as histamine gets released, it does nothing on my hair, nothing on my fingernails, but I do have histamine receptor sites in my lungs. That's what's causing the vasoconstriction. bronchoconstriction. I have histamine receptors in my vasculature. That's what's causing the vasodilation. I have histamine 2 receptors in my stomach, which is when I'm having an allergic reaction, I might throw up. That's why we give them Pepcid to counteract that. Now, histamine is not epi. Histamine goes to histamine receptors. Epi goes to adrenergic receptors. The thing is that our sympathetic nervous system and the receptors controlled by epi largely are so much more powerful than the effects of histamine. That's why giving somebody epi is to save their life, but giving them antihistamine largely just helps them be more comfortable. So if we've got an opiate molecule binding to an opiate receptor, giving us feel-good juice and also stop breathing juice, we give Narcan to boot that out, right? Antihistamines like Benadryl and Pepcid bind to the site a little like Narcan would to an opioid site and prevents the binding of histamine and Isaac, right? Epi is not working on our histamine receptor sites. It's working on the far more powerful receptor sites to overpower it. So I get stung by a bee. I get low blood pressure because histamine is going past all my veins and arteries, causing widespread vasodilation. I give epi that goes by the same vasculature, now binding to A1 sites, alpha 1 sites, and overpowers those histamine effects, causing vasoconstriction. So we need to know alpha 1 receptors. We also need to know beta 1 and beta 2. How many hearts do you got inside your body? How many lungs you got? 2. Beta 1 sites affect the heart. Beta 2 affects the lungs. What beta 2 agonist do we have? Close. Albuterol. Albuterol is an adrenergic. It works on the sympathetic nervous system. Agonism means it binds to a site and it elicits a response. Albuterol is a beta 2 agonist. It will flow into my lungs, go to the beta 2 receptor sites, and cause a response. An antagonist may bind to a site and prevent a response. That's like Narcan. It still binds to the site, but it prevents it. That's like Benadryl. Benadryl is an antihistamine. It's a histamine antagonist, right? So to highlight all of the language here, beta 1, if I give you epi, and it has beta 1 effects, it'll increase your heart rate, the squeeze of the heart, contractility, and also the electrical conduction of the heart, how well it's conducting signals. Epi is great for raising your heart rate so long as that's what you want. Well, histamine doesn't work on these alpha and beta cells, but it does have similar effects. A B cell sees a bee sting, it starts making IgE. After a while, you get stung again. All that IgE has bound to your basophils and your mast cells, and they're like, oh, I knew you was coming, so I baked a cake. And they explode, and histamine floods your body. Now, if that histamine floods your body and it goes to your lungs, what would the symptoms be? Bronchoconstriction, spasming, wheezing. If that histamine releases in your vasculature and binds to your blood vessels, what would we see? Vasodilation. How would that present itself? Because we may not see it necessarily. Hypotension for sure, but it may also look like redness and swelling. Wheals, urticaria, what's the other one? Hives are essentially your capillary sphincters being dilated and fluid escaping into the skin, right? This is kind of my best way of summarizing what these things do in as short of words as possible. This sympathomimetics, things that mimic the sympathetic nervous system, is synonymous with adrenergic, or adrenergic hormones like epi and norepi. Alpha receptor sites, if agonized, cause vasoconstriction. What happens if an alpha 1 site was antagonized? Probably the opposite, or at least preventing this. Beta 1 receptor is heart rate contraction and conduction, and beta 2 involving our lungs is bronchodilation. Let's see. What's also important to know is, and it's a far longer process to have a conversation about, but in short, not only does epi overpower histamine reactions by causing all of these alpha and beta effects that will save our life, it also literally stabilizes cells, making them less likely to degranulate and release histamine. Now, part of the issue is as much as it can overpower the histamine reaction, if histamine is in our system, this is what happens all the time. I'd be working with a medic, I'd see a medic at the hospital. They'd say, oh, I had a guy with an allergic reaction, so I gave him epi. I'd say, great, how much Benadryl did you give him? Benadryl is an antihistamine. And he'd say, well, why would you give Benadryl? I gave him epi. I say, well, because epi overpowers the histamine response, and it prevents the release of histamine. But he's already got histamine in him. That's why he had a reaction. Epi is not binding to histamine sites, it's overpowering histamine reaction by binding to adrenergic sites. An antihistamine like Benadryl does bind to the sites and prevents them. So my expression to the medics would always be, you should always give epi and Benadryl. Yeah.
So within like a paramedic scope, it's kind of like not or, it would be and.
It would be and. There are times I would give isolated Benadryl only if they had an isolated rash. I would never only give epi. I would always give epi and Benadryl.
So epi doesn't stop it. Benadryl stops the histamine release. So
No, you're okay. Epi does stop the histamine release, but it doesn't bind to the sites. So if you've already got histamine in there, it'll keep binding.
So, okay, so the Benadryl is kind of like limits.
Yeah, it's like let's say you have 10 histamine released, and in a few minutes you'll have 20. Well, epi prevents that 20. Let's say 5 out of those 10 histamine have bound to receptor sites and are now causing low blood pressure. Epi is overpowering that and causing vasoconstriction, but you still got 5 floating around in there. It's the Benadryl that will prevent those 5 from binding and causing more issues. So this is a bit of a weird situation where I'd say, hey, listen to me when I tell you, you shouldn't do any meds outside of your scope. It is never the right answer in here. It is never the right answer on the registry. I also don't think you're crazy if you tell someone to take a sip of their own children's Benadryl. It's the wrong answer. It's illegal. But antihistamines are largely harmless, and they can be very helpful in stabilizing your patient. If I have an allergic reaction test question or a practical scenario, don't tell them to drink Benadryl. It's not in your scope. Poison control, if you're not sure what they took, if the epi isn't working, 2 2 2 2 2 2 2 2 1 2 2 2 2 2 2 2 2 2.
I was trying to figure out, like, I remember, like, a little mnemonic that, like, it didn't work.
1 bunch of 2s on either side. That's how it's done. Or save it in your phone. Or Google it. I know the immunology is dense and it's deep. What you really need to do, what the test is going to be chock full of in regards to immunology, is some vocab, but mostly just, look, I'm about to release you like sheep amongst the wolves. I need you to suspect allergic reaction. I need you to be intimately and romantically, like at least second date familiar with your intervention cards. So when you see something and you're like, boom, this is an administer X, administer epi, administer aspirin, are there indications for it? And is there an absence of contraindications? Your patient fell down the stairs. There was a bee flying around him. He was swatting at it. He fell down the stairs, now he's hypotensive. Should you give epi?
might be bleeding.
Did he get stung by the bee? Because if he fell down the stairs and he's hypotensive, he might have trauma. It might be bleeding, and epi will kill him. If he got stung by the bee, okay, maybe, but I'm still like, you fell down the stairs. I'm going to try to manage your symptoms without it. Because what if this is an internal bleed, right? So there's a lot going on. But when you approach the final, largely it's going to be, this guy has these conditions. What do you think? Lastly and quickly, we'll break down active and passive reactions. Your book labels it as active and artificial, which is weird.
Does sound weird.
Active means if you've developed an immune reaction through an active process, it means you were exposed to a virus. Whether I got too close to Landon and got all of his viruses, or whether I asked for it from the hospital, they put a bunch of dead viruses in a vial, and that's what a vaccine is. But in any case, active means I was actively exposed to a virus. If I'm naturally infected by something in the wild, that's a natural active. If I'm artificially, that's the vaccine. Okay? It all comes down to viral exposure. See, in an active, we're exposed to this, and then my body's making antibodies flowing around my system. Passive isn't exposure to the virus, then your body making antibodies. Passive is literally, I take antibodies and put them in you. My body made them, and now I'm putting them in you. And I might do that with my breasts. Just got to try harder. Or the literal injection of the immunoglobulin, which is an immunogoblin. He's got a little sword, and never trust him. He tells many lies.
Never.
Antibody is essentially what we're talking about. So active is being exposed to the virus, and then your body makes antibodies. Passive, whether it's through breastfeeding or a placenta or literally somebody, it's you getting the antibodies, not your body making them.
Okay.